Assalamu alaikum. My name is Dr. Waqas Shafiq, and I'm moderating this session along with Dr. Ahmed Imran. And this is the Acute Oncology session in which we are going to talk about acute management of upper GI bleed, myocardial infarction, and calcium disorder in cancer patients. So I would like to invite our first speaker, Dr. Asim Yusuf. He's a consultant endocrinologist at Shaukat Khanum. So,
Assalamu alaikum. Thank you all for coming so early in the morning. Until very recently, I was a gastroenterologist, but I'm delighted that Waqas considers me intellectually capable of being an endocrinologist. It's fine. So I was asked to speak about evaluation and acute management of upper GI bleeding in cancer patients. And this talk is based heavily on the American College of Gastroenterology guidelines, which were published in 2021. The most comprehensive and the most up-to-date guidelines on this. And so the talk will be a mix of really just representing the evidence, some of the recommendations from the guidelines, mixed with some of our personal experience and some particular unique considerations in cancer patients with upper GI bleed, obviously interspersed with the usual witticisms that you would expect. So I have no disclosures. The outline is that we're going to talk about the initial risk assessment of patients with upper GI bleed in the emergency department, early stabilization and management, pre-endoscopic and pharmacologic treatment prior to endoscopy, then endoscopic treatments, post-endoscopy management, what to do with patients who rebleed after initial control or in whom control is not possible, and finally, unique considerations in cancer patients with presenting with an upper GI bleed. So in terms of initial risk assessment and stratification, a number of risk assessment scores exist. You'll have heard of many of them, the Rockall score, the Glasgow-Blatchford score, and others. Glasgow-Blatchford score is the most widely used and is the one recommended by the guidelines today. These are the key features of the Glasgow-Blatchford score, and without going into too much detail, essentially, if you have a high blood urea nitrogen, your hemoglobin is low, you've got tachycardia, hypotension, and any of the melena or syncope or a previous history of heart disease manifested by heart failure in the past, and acute or chronic liver disease based on history, radiology, and lab tests, then your score is higher. So in other words, if you score low on all of those, if your urea nitrogen is normal, you're not hypotensive or tachycardic, you've got no melena or syncope, your score will be 0, and that's considered low risk. And so the guidelines suggest that patients presenting to the emergency department with an upper GI bleed who score very low on this, who have a score of 0 or 1, who are hemodynamically stable, in other words, should be discharged with outpatient follow-up and don't need to be admitted to hospital and don't need urgent intervention. But of course, in a cancer hospital, we always need to remember that there may be other or oncologic reasons for their admission. They may be neutropenic or febrile or something else. So it shouldn't just be based on the Glasgow-Blatchford score alone in cancer patients, but we need to look at the patient holistically. In terms of transfusion, the guidelines, again, are quite prescriptive, and I think this is generally recognized for a number of years now, that a restrictive policy should be used. In general, we only recommend transfusion when the hemoglobin is less than 7, and this has been shown to reduce the risk of further bleeding and death. However, hypotensive patients may need to be transfused at slightly higher hemoglobin levels because once you've given them a lot of fluid, their hemoglobin will obviously actually be lower than it first seemed. And again, patients with pre-existing heart disease should be transfused at a slightly higher threshold of 8 grams per deciliter. Again, in cancer patients, don't forget that it isn't just the hemoglobin we need to look at. In general GI, perhaps we don't worry too much about the platelets and so on in everyday practice. But in a cancer patient particularly, we also need to be cognizant of their platelets, their clotting, any anticoagulants or other treatments they may be on that may be affecting the way they bleed. In terms of pre-endoscopic medical therapy, again, this has been shown treating patients with pre-endoscopic medical therapy in order to empty the stomach prior to endoscopy improves visualization and the diagnostic yield of the endoscopic procedure And this results in a higher proportion of patients receiving appropriate endoscopic treatment. You can understand that if there's a large pool of blood or blood clots in the stomach, they will obscure the view of the mucosa, and that will limit the kinds of your diagnosis, first of all, as to where the patient's bleeding from, and will also limit your therapeutic options. And so again, the guidelines are clear on this, and there's lots of data on this over at least 15 years now, that an infusion of 250 milligrams of erythromycin should be given over 30 minutes, at least an hour prior to endoscopy. This has been shown to reduce the need for repeat endoscopy and therefore reduce the length of stay, but it hasn't been shown to improve clinical outcomes such as further bleeding. In Pakistan, IV erythromycin is very rarely available, if at all. I'm not sure if it's ever available. We've tried in the past and not been able to get it. Local practice, and indeed practice in many parts of the world, is to give a larger than usual dose of metoclopramide or another promotility agent to try and hasten gastric emptying. Now, PPI therapy is PPI therapy is a contentious issue as to whether PPIs should be given routinely to patients with upper GI bleed. Earlier studies had several flaws, and the group shown at the bottom right there, the Hong Kong group, is really the world leader in investigation and management of upper GI bleeds. They've done the largest randomized controlled trials on this subject. And in 2007, they published a very large randomized controlled trial of 638 patients with upper GI bleeds who were enrolled and randomly assigned to receive either omeprazole or placebo prior to endoscopy. The results are summarized in the table, and is there a pointer? So you see the bottom line here. It was shown that infusion of high-dose omeprazole before endoscopy accelerated the resolution of signs of bleeding in ulcers and reduced the need for endoscopic therapy, and that was statistically significant. So 60 in the omeprazole group and 90 in the placebo group. And that was a statistically significant p-value, but there was no evidence of reduction in further bleeding or in mortality. So again, giving a PPI infusion prior to endoscopy may result in earlier resolution of the signs of bleeding and the requirement for endoscopic treatments, but doesn't affect bleeding or further bleeding or mortality. And so in the past, and I'm sure you're familiar in your own specialties, guidelines used to be more vague and say things like could be considered or might be considered or whatever. The ACG guidelines were very clear in not using that kind of language, and they were more prescriptive as to whether they did or did not approve of something. And this was the one indication where they were unable to provide that clear recommendation. And so they have not recommended for or against PPI therapy. Using PPI therapy, intravenous PPI therapy in all patients with upper GI bleed obviously has cost implications. There are adverse effects associated with the use of these drugs and so on. But you have to balance that against the clinician's urge to do something for a patient prior to their bleed. So it's still commonly and widely used PPI therapy, 80 milligrams IV stat and then 8 milligrams an hour and so on. But there is no clear recommendation or evidence either way. Again, important to remember other drugs that the patients may already be on, particularly in cancer patients, such as anticoagulants. Now, when should patients presenting with an upper GI bleed undergo endoscopy? So the recommendation is that patients admitted to hospital for an upper GI bleed must undergo endoscopy within 24 hours of presentation. When I was training, the rule was as soon as possible, within 6 hours, then within 12 hours. But again, there's a number of studies which have shown that doing an emergency endoscopy in the middle of the night makes it more likely that it'll be a junior endoscopist who's doing it, a registrar or someone less experienced. The usual endoscopy unit staff who are skilled in assisting and in helping with these procedures will usually not be available, and it'll just be a nurse from the endoscopy unit or the OR or someone who's not familiar with endoscopic techniques. And that actually results in an increase in morbidity and mortality. So again, the recommendation is within 24 hours so that you can try and do it within working hours as far as possible. Very early endoscopy may cause harm if resuscitation and management of other comorbidities is not undertaken prior to endoscopy. But again, there's always a caveat. So patients who are hypotensive as a result of their GI bleed at presentation, and in whom you're not able to restore a normal blood pressure, are likely to need urgent, immediate endoscopy. And this is a very small but very sick cohort of patients who will always need to be intubated and to have their airway protected and have an anesthesia team in attendance for continuing resuscitation and monitoring while you try and scope them. Again, in these patients, you won't usually have time to give in erythromycin or other things to empty the stomach. So these are high-risk procedures and will often be unsuccessful at the first attempt in controlling bleeding. So again, endoscopy should be done within routine hours as far as possible. And this also helps in early discharge in a substantial proportion of patients with low-risk endoscopic findings. We'll talk about what those are in a second. And obviously, early discharge of such patients reduces the length of hospitalization and overall hospital costs. So this is what we call the Forest classification of bleeding from gastrointestinal ulcers. So Forest 1A is where you have a spurting bleed. You can see this arterial jet coming from the base of the ulcer. 1B is an ooze, where it's a larger area that the patient is oozing from, no one bleeding point. 2A is a non-bleeding but visible vessel, this black dot here, and then adherent clot, flat spot, and then just a clean ulcer base. So again, when I was in training, the teaching used to be that if you see a clot, leave it well alone, don't touch it. Today, the recommendation is that you do everything possible to remove that clot, including snaring it if you have to, so that you can see which of these Forest classes the patient is in. Do they have a visible vessel that they're not actively bleeding from? Are they oozing as soon as you remove the clot? Or is it one of these categories? And the reason is that patients who have the first three, so an oozing vessel, a spurting vessel or oozing bleed or a non-bleeding visible vessel, are the ones in whom endoscopic treatment is recommended. Whereas the last two, you don't need endoscopic treatment, you can treat medically. Again, this is data from that same group in Hong Kong, published in 2009. They did a meta-analysis of 19 randomized controlled trials of endoscopic therapy. An important caveat is that they only looked at patients they only included trials which did not have a second look endoscopy or retreatment. So it was trials of patients in whom the first endoscopy was the only one. They looked at the primary endpoint of whether further bleeding occurred or not, and found that further bleeding was significantly reduced, first of all, by endoscopic treatment, and secondly, by the combination of adrenaline injection and another modality, as opposed to endoscopic therapy alone or adrenaline alone. So you need two modes of treatment when you treat a bleeding ulcer. Either adrenaline alone or endoscopic therapy alone is not sufficient. Within the endoscopic treatment modalities, there are a number of devices available. I'll show you some pictures of a few in a second. And they're all pretty much similar in their efficacy. A lot of it depends on local availability, cost, and the familiarity of the endoscopist with various devices. So again, we've talked about this. So these are just some images. Most of these are from our own hospital, I'll tell you. So that's an ulcer with a visible but non-bleeding vessel in its base that you can see there, and it's been successfully clipped. So these two images are our own. This is not new now, it's been around for about 15 years, but it's called an Ovesco clip or over the scope clip. You attach it to the end of the scope, go into to wherever your bleeding point is, suck that lesion up into the biopsy channel of the scope, and then deploy the clip so it releases from the scope and captures a much larger chunk of tissue. It's a full thickness bite of the gastric wall or wherever you are in the intestine. These can be used in the colon as well. This is not one of our own images. We have used this in a couple of cases, but we didn't have as good an image as that. So this is actually an image from a paper. And again, then this is an ulcer with a visible vessel following thermal treatment. Most of you will look horrified and think that looks a lot worse than when we started, but actually that is the end result of thermal treatment, and that's a very good endoscopic outcome. Then we have hemostatic powder. So this is, as the name suggests, a powder which you spray over the surface of a bleeding area. It has hemostatic effects. It contains fibrin. very good for almost instantaneous control of bleeding. So an oozing ulcer there, halfway through, and at the end, it's all stopped. But the powder is really only a temporizing measure. You need to then carry on and do something else. The powder will be washed away by salivas ingested or gastric secretions within the next few hours. So it's not a definitive treatment in and of itself. Just some more images. Again, these are our own images. A slightly newer form of treatment. We don't have this yet in Pakistan, and so these images are not ours. But Puristat, that's a trade name, is a synthetic hemostatic material composed of peptides which assemble into a scaffold which mimics the human extracellular matrix. And so in these images, you see an ulcer over here at 3 o'clock and a black ulcer here at sort of 7 o'clock. This is the esophagus. And these are ulcers in the lower esophagus following a patient who's had banding for varices. So post-banding ulcers are not uncommon and often will bleed again, and that's not a variceal bleed, that's an ulcer bleed. So what you do with this is Puristat is it's a gel, and you inject it through a catheter directly onto the surface of the ulcer. It can do one of two things. So it because the gel solidifies within minutes. And so in many cases, you can just leave the gel there alone as a sort of shield to protect the ulcer from ongoing acid exposure, and that will result in gradual healing of the ulcer. If you've got a bleed, then you can instill in Puristat over the ulcer, again, just to control the bleeding temporarily. You can see the visible vessel or whatever it is through the clear gel, and then you can apply your clips or whatever through that. So it's a very neat technique. And I'll just show you very quickly. You see the gel coming out there, you see? So that's it. Again, we don't have that here yet. It's 250 euros for 5 ml. So if we do get it, we'll be using it very sparingly. Now, what about PPIs after endoscopic hemostatic therapy for bleeding ulcers? So we talked about pre-procedure. In anyone who's had endoscopic hemostatic therapy for a bleeding ulcer, you do need to continue high-dose PPIs intravenously for 72 hours. And thereafter, they need to continue oral PPIs for another 2 weeks. Once again, the group from Hong Kong in 1999 did a randomized trial of endoscopic retreatment versus surgery in patients with recurrent bleeding. So we've controlled the bleeding initially, and then they recur. They have a further bleed. So in this trial, they looked at a number of parameters: further bleeding, death, the need for surgery for rebleeding, or complications of the endoscopic procedure, and the length of stay. And they found that in the patients who were randomized to receive endoscopy treatment for rebleeding, while there was an increased risk of further bleeding compared to surgery, there were fewer complications and no significant difference in mortality or length of stay between the patients who received endoscopic retreatment versus those who had surgery. And so the guidelines here are very clear that patients with rebleeding after initial hemostatic control of a bleeding ulcer should undergo repeat endoscopy rather than have surgery or radiologic intervention. So first endoscopy, you control the bleeding, patient rebleeds, should have a further attempt at endoscopy before going on to other forms of treatment. Obviously, if they have failed that second attempt as well, then the next step is an interventional radiology procedure. And in these patients, it has been shown that embolization will, while again is associated with an increased risk of further bleeding compared to surgery, has much fewer complications, shorter length of stay, and no increase in mortality as compared to surgery. So surgery is the third option for intervention in patients who have recalcitrant or difficult to control bleeding. Just one slide on varices. Again, it's a whole talk in itself, so I've just really summarized it. Same sorts of things: restrictive RBC transfusion strategy. Risk stratification in these patients is according to their Child-Pugh score or the MELD score, and not according to the Glasgow-Blatchford score. All patients should receive a vasoactive agent such as terlipressin or octreotide from the time of presentation. All patients with varices or suspected varices should receive a first dose of ceftriaxone, antibiotics, intravenously. Again, they should receive an agent to help empty the stomach. For esophageal varices, the treatment of choice is banding of varices, not sclerosing agents. For gastric varices, glue injection or cyanoacrylate injection, we don't band gastric varices. And in patients who have recurrent bleeding or in whom you cannot control bleeding with banding or glue injection, the next step is a TIPS. You will see there's no mention of a Sengstack and Blakemore tube. That is not used anymore. Finally, there is evidence, mostly just case series and case reports, for the use of a fully covered metallic stent in the lower esophagus to cause tamponade of bleeding varices. Now, coming to the last part of the talk, unique considerations in cancer patients. Cancer patients are at higher risk for GI hemorrhage due to bone marrow suppression, the effects of cancer treatment, and disorders of hemostasis, either secondary to the cancer itself or to its treatment. And it's known that a cancer diagnosis predicts poorer outcomes from GI hemorrhage. A review in 2013 looked at the causes of upper GI bleed in cancer patients. There was a tumor bleed in almost a quarter, variceal bleed in about a fifth, ulcers in about 16%. And while the mortality in the general population from upper GI bleeding is up to 20%, in patients with cancer, this increases up to 45%. So the management here is complicated by the expanded differential, as we discussed, the fact that often it's a tumor bleed, which is much harder to control. Interesting that GI guidelines still refer to bevacizumab as a newer agent, but there are newer cancer agents all the time, and some of those have an increased risk of causing GI bleeding. The cancer or its therapy can lead to bone marrow suppression and thrombocytopenia, and as we've said, some of the newer drugs have weird and wonderful side effects that we need to be aware of. So direct tumor bleeding is problematic, but does often respond to endoscopic measures. In many cases, there will be a visible vessel or a spurting vessel, which is treated in exactly the same way. The problem is that the cancer tissue is often more friable than the normal surrounding gastric tissue, and around an ulcer, the mucosa is usually fibrosed and tougher, whereas often with a tumor, the mucosa will break away as you apply a clip. So that can make it more challenging. And therefore, recurrence rates are high. But there are additional non-endoscopic therapies which can control bleeding and reduce the recurrence of GI bleeds. These include tamponade by a metallic stent, again in the esophagus, is very effective for bleeding from esophageal tumors. And last but not least, we have our radiation colleagues here as well. Radiation therapy is the final form of treatment that we can use to help in management of difficult to control tumor bleeds specifically. So this is just one of our patients. You'll see a diffuse ooze from this tumor in the esophagus that we couldn't tell a particular point that the patient was bleeding from. It was just bleeding from everywhere. Put a stent in with almost complete and instantaneous control of bleeding. Took the stent out a week later, and again, there's no further bleeding. So that was a very pleasing outcome. So thank you for your attention, and I'm happy to answer any questions.
Thank you, Dr. Asim, for an excellent talk. I don't see any hands raised in the audience, so I'll take most of this opportunity. So gastroenterologists are usually at the receiving end when the referral is sent to a gastroenterologist from internal medicine. You have outlined briefly in terms of what needs to happen for a patient to safely undergo endoscopy. Is there anything in particular in cancer patients, what would you like to have happen before the referral lands on your table? That what should the patient be stable and what should we do?
Yeah.
Because otherwise it is counterproductive for patients. We're wasting time back and forth.
Correct. Yeah, well, as a joke amongst gastroenterologists, what we want is that the patient be lying on the endoscopy table in the left lateral position with their mouth open, and we just scope them. No, but, this is, I guess it's shared care, but most of this should have been done in the emergency room. They should have been assessed and risk stratified. They should obviously have IV access, and they should have fluids up, blood transfusion if appropriate. Their platelets and clotting should have been checked. PPI therapy, that again is up in the air, but I think on balance, we continue to use it in our hospital. And again, in cancer patients particularly, although there's no evidence for this, but given that it's more multifactorial, they may be bleeding from more than one place. Control of bleeding is more difficult. You want to try and improve your chances as much as you can prior to endoscopy. So I would suggest we do that. And very important, and something that is not often, but occasionally overlooked in the emergency room, is that No one bothers to check whether the patient is nil by mouth, when did they last eat or drink. The most simple thing often gets left out. They've had all the more complex stuff. Obviously, we need the patient to be nil by mouth for at least 6 hours in order to do a safe endoscopy, and use of a pharmacologic agent will aid that. But generally, we don't want to scope them until they've been nil by mouth for at least that long. And finally, we want an assessment of whether their conscious status is such that they can undergo safe endoscopy with monitored sedation, or whether they need formal airway evaluation and protection of their airway.
So is there any role of IV omeprazole in patients with tumor bleed? Because when they come to the emergency, we don't know. Patients with the upper GI tumors, we think likely it is tumor bleed.
So, that's what I'm saying, that there's no specific evidence as to whether it should, these guidelines didn't look as tumor bleeds as a subgroup. So the court, the verdict is not clear as to whether they should get PPIs or not. On balance, as I said, we tend to give them because prior to endoscopy, you don't know whether it's a tumor bleed or not, obviously. Secondly, they're sicker, they have other reasons why they might be bleeding, and so we want to try and maximize our chances. And thirdly, they may, cancer patients may be on non-steroidals and other things which may increase their risk of bleeding further. So I think on balance, we would have to continue to say in our setting and in a cancer patient, it's probably just as well to err on the side of caution at the moment and give a PPI. But that's a data-free zone. Right. So it's not a glue. Sorry, I may have misspoken if I said that. It's a gel. It just covers the ulcer base or wherever you inject it, and it solidifies in a few minutes after coming into contact with gastric secretions. So it's not a glue. It's not something you inject. You use a cannula to inject, but you just spray it over the ulcer. What its exact composition is, I don't know. It's some kind of formulation of peptides. I don't know what it contains exactly.
Hemorrhage or a massive hemorrhage?
So the HALT-IT trial was published a couple of years ago, which showed very conclusively that there is no role for tranexamic acid in upper GI bleeding. As it happens, Shaukat Khanum Hospital was a participating center in that trial, so we never failed to plug that. Okay.
Right. Any more questions from the audience? Well, thank you, Dr. Asif,
Thank
for
you.
the excellent talk. Thank you. So I'll move on to our next speaker, Dr. Saqib Bukhani. He is a consultant interventional cardiologist at Darent Valley Hospital, UK, and he will be talking to us acute cardiology related acute oncology issues. Thank you.
You can hear me clearly? Yeah. Okay. Good morning, everyone. Assalamu alaikum. And first of all, thank you for the invitation to the Shaukat Khanum committee, Dr. Asim, Waqas, and all of you. I'm here from London, but I have been here before. This is 23rd Symposium of Shaukat Khanum, and exactly 23 years ago, I did my clinical electives in Shaukat Khanum when I was a fourth-year medical student. That does give away how long I've been a doctor, but I've been in the UK about 20 years now. And so I'm an intervention cardiologist in Dartford, which is a little town outside London, and I live in London. And on a daily basis, I'm an intervention cardiologist, which is a plumber. So my job is to open up blockages, but we like to deal with everything that comes along. I do not have any conflicts of interest to declare, apart from the fact that Waqas is a very old friend of 27 years. I'm not sure if it's good news or bad news for you, but thank you. What we'll go through today is just a brief overview of management of acute coronary syndrome or myocardial infarction, but the focus will be on cancer patients because that's a challenging area for cardiologists as well, because it's a research-free area. There's not much evidence around. So acute coronary syndrome, without boring you too much or taking it into too much detail, in summary, is referring to a condition which is caused by sudden reduction in blood flow to the heart itself. Now, if you define the types of myocardial infarction, I could be here for another half an hour. But just to summarize, type 1 myocardial infarction is what we think of on a daily basis, a heart attack due to a blocked vessel. That's type 1. All the others, type 2, type 3, are due to reduction in blood flow, but not necessarily due to blockage. It could be stress-related factors, ischemia due to hypotension, sepsis, malignancy, all these things. So myocardial infarction is a broad category and may or may not include blockage of coronary artery. But when we think of various types of myocardial infarction which patients can suffer from, let's not forget cancer patients are actually prone to the same phenomena as other patients. ST elevation myocardial infarction is what we get excited about. This is what drives adrenaline in our bloods. We wake up in the middle of the night, and the guidelines are if there's an acute blockage with ECG changes, the European guidelines are we need to open up the coronary artery within 2 hours of the onset of symptoms. So from the time they call the ambulance to the time we stick a wire and balloon on the coronary artery, it should be 2 hours. It's achievable in some centers, not achievable in some, but it depends which part of the world you're working in. Then if you move to non-ST elevation MI, which is the bread and butter of ischemic heart disease, most of the patients worldwide, when they experience a heart attack, it is non-ST elevation MI, which you all are aware of. Your relatives, your friends, people you know, they've been admitted with chest pain, increased troponin levels, may or may not have ECG changes. They may be in hospital for a day or two. Then they have an angiogram, they get treated, they come home. That's non-ST elevation MI, and that's the big bulk. The third category can be unstable angina, where they may not have acute blockage in the artery, but the symptoms are getting worse. And we may treat them as inpatient or outpatient, followed by chronic coronary syndrome, which is also called stable angina, which you can manage on a routine basis. So how is management of acute coronary syndrome or myocardial infarction a little bit different in cancer patients? Firstly, cancer and its treatment can itself increase the risk of cardiovascular events, including acute coronary syndrome, and cancer patients are on average 2 to 3 times more likely to suffer cardiac events. That's a known fact. There is increased cardiovascular complications in cancer patients, especially those who are receiving chemotherapy or radiotherapy, and higher incidence in older patients. Breast cancer, lung, and hematological malignancies, along with GI cancers, have been reported to be more associated with cardiac complications and ischemic heart disease. They're also the ones which are more challenging to treat because they have high risk of bleeding at times. And as I've already mentioned, non-ST elevation MI is the most common presentation amongst all the ischemic heart disease. And the interesting fact is, if you look at all the research data, there's hardly any randomized controlled trial on how to manage myocardial infarction in cancer patients, because cancer usually, in fact, in every trial, is a part of exclusion criteria. So anyone with cancer is not recruited into trials. So it's a research-free zone, hence it makes it more interesting because it's easy to apply guidelines. It's more fun when you have to take each case individually. Cancer as a risk, there's vascular damage from cancer therapies, chemotherapy, and radiotherapy. There is systemic inflammation with cancer and its treatment. And we now know from research that coronary artery disease is actually an inflammatory process. It's not just a thrombotic event. It's an inflammatory process, and CRP on its own is an independent risk factor for coronary artery disease. And hence we have noticed an accelerated incidence and prevalence of coronary disease after COVID infections, COVID pandemic, because the inflammation has gone up in everyone's body. There are increased thrombotic states in malignancy. They are more hypercoagulable. There is direct cardiotoxicity as well. And then obviously from various other hormonal treatments, there is risk of hypertension and thrombosis. This is something I came across it's a meta-analysis in Journal of Clinical Medicine published recently, and it's nicely outlined. If you look at the bottom half of the slide, or this diagram, most of the risk factors which are there for cardiovascular diseases, diabetes, hypertension, obesity, smoking, low physical activity, they're also risk factors for cancer. So they go hand in hand. But what makes it more difficult is often cancer patients have anemia, hypoxemia, hyperviscosity. That also increases the risk. So it's a vicious circle, and one thing adds to the other. What I'll do now is I've actually brought a couple of cases which I myself dealt with within the last 12 months of cancer patients being admitted or being treated for myocardial infarction. And I have a case of an 82-year-old male whom I met, I think 3 months ago. He had a history of hypertension, atrial fibrillation. He was on 2 antihypertensive medicines with very well-controlled blood pressure. He was on apixaban and a beta blocker for his AF. He also had basal cell carcinoma on the scalp, recently excised about a month or 2 ago, but then it reoccurred for the second time and looked very aggressive and nasty. I don't have a picture of it, but it was concerning to him, definitely. Although he's 82, but it was in an area where it affects his quality of life. And he was now waiting for surgery for the second time, but he got admitted with acute chest pain, exertional breathlessness, and although his examination was unremarkable, apart from the fact there was a systolic murmur, he was kept in hospital because of his symptoms. So we love ECGs. We don't do much without these pink pieces of paper. His ECG, as you can see, shows atrial fibrillation with a well-controlled heart rate. And in the interest of time, you don't see any acute ST elevation, nor depression. But if you're very strict on it, there may be very subtle T-wave changes in inferior leads, but there are some artifacts there. So in a nutshell, this ECG wouldn't worry me or excite me, as you call it, in the middle of the night, but the patient is admitted. His blood tests, sorry if it's a busy slide, but his hemoglobin is normal, the key factors. His platelets are normal. His renal function is normal. He had recently been treated for chest infection. His CRP is slightly elevated. It might also be related to his BCC. We don't know. And very borderline abnormality in his bilirubin count. I don't know why. What other tests do we need? Any other? Cardiac enzymes. His troponin. In our hospital, the normal value is 0 to 14. So his troponin was more than 3,000 on day 1 of admission. So we are now dealing with non-ST elevation myocardial infarction in someone who's awaiting surgery for a scalp tumor. He had a murmur as well. So an echocardiogram was done, and he's got severe aortic stenosis, although he's got good heart function. So 82, but performance rated 1. He lives alone, does everything himself. Now, at this stage, we had this case of MI, aortic valve disease, and ongoing cancer. Question is how to treat him. What should be our top priority? What is patient's top priority? We had some options. Options were we perform an angiogram, do a surgery because he's got valve disease as well. Another option is angiogram and consider stents. Third option was just give him tablets, make sure he's fine. Fourth option is stop heart cancer treatment, stop all the heart medications and just focus on his cancer surgery. So maybe none of them were applicable, but just a show of hands, what do you think? How many of you thought we went with option 1? Anyone? Option number 2? A few hands coming up. Option 3? And option 4? And some of you have taken none of the options, which is good. Good. So this makes it interactive. What did we do with him? We took him to the cath lab. Bearing in mind his performance rate is 1. He's looking after himself. He should be treated like any other person. Obviously, cancer is an issue there. But doing an angiogram doesn't mean that we are obliged to perform any procedures beyond that. But at least we wanted to know, and the surgeons would want to know what his coronary status is before they put him under general anesthetic. Although he's been under it already 2 months ago. So it shouldn't be that bad. Anyway, this coronary angiogram, there are 3 coronary arteries, and you'll have to believe me, the other 2 are fine, the left anterior descending and the left circumflex. But in the right coronary artery, there's a severe stenosis in the mid-segment, as you can see, where the branch is coming off. Now, to a naked eye and to an intervention cardiologist, it's a straightforward case for PCI. Will probably take 10 minutes to fit a stent in. But this guy is awaiting surgery for a tumor, which is growing rapidly. And it is scheduled in 2 weeks from now. Questions? What do we do again? Do we proceed with the stent? Because if you're putting a stent in, it's not just a stent. It's the post-procedure management. He needs antiplatelet therapy. He needs high-dose heparin during the procedure. Interrupting the antiplatelet therapy for surgery is a risk for stent thrombosis. All these factors have to be taken into account. Or just give him tablets and wait and watch. Or surgery, because surgery does not need antiplatelets, although it's a big operation. We opted for medical therapy. We gave him dual antiplatelet because, and remember, he had atrial fibrillation as well. So there was another risk factor of bleeding. He needed anticoagulants with it, triple therapy, for a month, and then stepped it down to single antiplatelet, which is clopidogrel with apixaban. We asked the surgeons to defer his, well, we decided to defer his PCI for any intervention. We said we'll think about it if needed, but we asked the surgeons to defer his scalp surgery by another 2-3 weeks so that he's at least completed 1 month following his heart attack, which should reduce the risk of perioperative complications. He had his surgery. There was no issue whatsoever. He remained completely asymptomatic from cardiac point of view. And it is now 4 months because I spoke to him last month. He's absolutely fine. No further angina. And on that basis, we have decided to leave his coronary artery alone for now. And with regards to his aortic valve disease, he's 82, he's got cancer. We don't need to give him open heart surgery. We can do it percutaneously with TAVI, which he's on a waiting list for. At the time of TAVI, which will be in 6 months from now on the NHS waiting list, his cancer will be cured, hopefully. And if it's not recurring again, we can put a stent in his coronary artery as well. So this was a good outcome on a case we recently dealt with. And very briefly, to cover up on the European Society of Guidelines on management of cardiac conditions in cancer patients. This brief summary is a 155-page document, but I've just picked up 2 or 3 slides or bits of information which are relevant. One thing is the history is key because symptoms are not typical in cancer patients. Often they present with fatigue, nausea, dyspnea rather than typical chest pain. So it can be easily missed. You have to differentiate. And then the risk stratification at the time of initial history taking is very important because 1 or 2 days down the line, they're sometimes already subjected to aggressive medical therapy or intervention. But if we miss out the opportunity of knowing what cancer they have, what is the stage of the cancer, what is their prognosis, I think that's the most important bit of information. And these patients, there's no rush. We should probably give it another day or 2, but make the right decision. In terms of diagnostic markers, troponin and BNP levels are very useful. Imaging, non-invasive testing is probably more useful in these patients than invasive angiograms. So echocardiography, I'm sure, and Shaukat Khanum echo is used very commonly, pre and chemotherapy, during chemotherapy, for other reasons, pericardial effusions maybe. But then ECG can be non-specific. Management, amongst the revascularization strategy for coronary artery disease, they still say that PCI is better. If the patient is fit enough for it, offer them stent. Just because they've got cancer, don't ignore them. But then choose drug-eluting stent rather than bare metal so that they endothelialize quicker and the risk of stent thrombosis is lower after a month. They may be able to shorten their dual antiplatelet to single antiplatelet after a shorter period of time. Nowadays, we are even using drug-coated balloons. So there's no stent. We just deploy a balloon with it's got drug coating on it, has got good results. As long as at the time of the procedure, the good result is achieved, 6 month, 1 year outcome is good. So you don't leave a stent in, there's zero risk of stent thrombosis, obviously. Surgery is reserved for complex patients only. In terms of treatment with tablets, although in the current era, we have moved into ticagrelor and prasugrel, which are slightly more potent than clopidogrel. What they do is they do keep the gastroenterologist busy. There's a lot of GI bleeds coming back. But in cancer patients, we prefer clopidogrel. We keep it simple. Bearing in mind, if they need anticoagulants, the risk is much higher. And then we have to keep in mind there are certain chemotherapeutic agents which interact with cardiac drugs. Complex area can't be covered in 2 minutes, but we have to refer to guidelines and just be sure we're not giving the wrong drug. If you look at literature review, I've already mentioned there's very little data or very little evidence from randomized controlled trials. So it's mainly registry data. And if you just look at some studies I've just came across, they've looked at a large number of patients in US who underwent coronary intervention, and they found cancer prevalence about 2 to 6% in those patients. Overall, globally, less PCI is performed in cancer patients versus non-cancer patients, 50% versus 80%. Patients with leukemia are less likely to undergo angiography. There's a risk of bleeding. These are all registry data. Another registry shows that 53% of the cancer patients in a Swedish study were given just conservative medical therapy, no intervention whatsoever. but obviously they have to be stable enough. But when we do perform the procedures, radial artery access is preferable. Nowadays, radial is default anyway, but keep the femoral access only and only for complex cases because there's increased risk of bleeding. Similarly, platelet count is relevant. 50 or 50,000, whatever units you're using, is probably the cutoff for angioplasty. Bearing in mind, these patients can become anemic post-procedure. And when we are transfusing patients, giving them hemoglobin or platelets, we are replacing their blood with blood which does not have aspirin and clopidogrel on board. So if they've got a stent and they require repeated transfusions, every transfusion is an additional risk for stent thrombosis because the blood is not thin enough. Special circumstances, we've already mentioned this briefly, but patients undergoing chemotherapy and radiotherapy, they need to be on cardioprotective agents to avoid the risk of coronary events. And with radiotherapy, surveillance is important because the risk of coronary artery disease stays long term. Once it starts, this process carries on, even if the radiotherapy is stopped. Nowadays, we can do non-invasive CT scans for that. We don't need to perform invasive angiograms. But I don't personally recommend it in everyone. It's only if they're symptomatic. Certain chemotherapeutic agents are linked with cardiac toxicity, cardiac side effects, and coronary artery disease. Something to bear in mind. And the most important bit, I think the most important bit in the European guidelines or any other guidelines you look at is personalized approach is management of ACS when it comes to cancer patients. In general population, we can convince the patient based on guidelines. In cancer patients, is the patient who matters more than any guidelines because the guidelines are not based on randomized trials. They're based on registry data. So every patient, they consent. What is it that they want? Like my patient I presented, his priority was his cancer treatment. He wanted to self-discharge when we mentioned option of surgery or stent. He said, no way, I'm getting rid of this cancer before you get rid of anything else. So, and we did what he wanted and he's happy. Life expectancy is a key thing. Anyone with less than 1 year prognosis, I think it is very unfair to subject them to any complex cardiac procedures unless really necessary. But if they have ST elevation MI and ongoing unstable angina, it is also unfair to let them suffer with chest pain during those 12 months. So it's a nice balance you have to achieve. Lower risk options. There are always options with lower risk. So stent is not the answer for everything. I'm an interventionist. I love putting stents in. But we have a lot of data coming through now recently that good medical therapy is as good as stents, especially in stable angina or even in low risk non-ST elevation MI in elderly patients, frail patients, and patients with multiple comorbidities or cancer. So tablets are coming back. Yeah, and our jobs might be at risk, but no, they're not. And end of life considerations. Patients who are end of life. The last thing we want is like presenting to emergency department. They've got palliative chemotherapy ongoing, and somebody injects high dose heparin, give them aspirin, ticagrelor before we get to see them. And by day 2 or 3, they start bleeding already. It's too late. I think we have to be very careful in aggressive medical therapy or aggressive therapy in patients who are end of life. So I'll finish off with one more other case. We've got 3 minutes. A very short one, 62-year-old male. I came across last year. He had a history of hypertension and arthritis and iron deficiency anemia. And most likely the anemia is what triggered the investigations. And he was found to have cancer at the lower end of his esophagus, T3 and 2. And he was awaiting further assessment, biopsy, and surgery. And this is when he mentioned, I think to the surgeon or the gastroenterologist, that he's got chest pain. Now that chest pain could have been put down to esophageal symptoms, dysphagia very easily. But that's where the referral came through to our department. And he came via rapid access chest pain clinic. His ECG was normal, blood pressure was normal, examination was normal. Now, how to investigate him? He's got risk factors for coronary disease. He has cancer, which they need to treat pretty soon. So he underwent a non-invasive testing. We didn't go for angiogram. He went for a myocardial perfusion scan. You can have stress echocardiogram, perfusion scans, cardiac MRI, you can choose. Our waiting time was the shortest with perfusion scan. Showed good heart function. And there was evidence of ischemia in anterior apical segments correlating with left anterior descending artery. And this is where I met him for the first time. So the question is, what do we do? So what I did, when I met him, he was hardly on any medications for heart. He had symptoms, but he wasn't optimally treated. Because the cancer was taking priority at this stage, we offered him very good medical therapy, put him on 2 agents, gave him 4 weeks to reassess symptoms, and reassuringly, he was absolutely fine. No further chest pain whatsoever, on the basis of which we decided there is no need for angiogram. If we perform the angiogram, I'm sure there'll be coronary artery disease. But if he's stable with tablets, why bother? He's not had a heart attack, it's just angina. And we advised to continue with cancer treatment. He then obviously initially planning for curative therapy. Unfortunately, he developed some cerebral mets. So they continued with palliative chemotherapy. But the good thing is it's been a year and he's had no cardiac symptom whatsoever. If we had put stents in at that stage, he probably could have come in with GI bleeds and other issues. So he's in a safe zone and he's comfortable. So I'll conclude by saying that multidisciplinary approach is extremely important when it comes to management of acute myocardial infarction in cancer patients. Benefit and risk ratio needs to be carefully assessed on a case-by-case basis, and patient consent and individual circumstances are pivotal in the absence of guidelines. Drug interactions is something to be aware of. Research is limited, and further research is needed. I don't think there will ever be a randomized trial in cancer patients because they take years and years for results, and cancer patients may not have many years. So cancer takes priority. I'd like to thank you all for the invitation and listening. Although I'm here today, but we have a group of cardiologists in the UK, and some of them are cardio-oncologists. So for future collaboration, I spoke to some of my colleagues who will be very happy to collaborate if any help needed. So thank you.
Well, thank you, Dr. Saqib, for this excellent talk. If there are no questions so far, yeah, there, go ahead, please.
Thank you, Dr. Saqib, for excellent talk. I'm Jamshed from Shaukat Khanum Cancer Hospital, working as a medical oncologist. So I have a question. Unfortunately, some of the patients develop chemotherapy-induced cardiomyopathy or requiring ACS, requiring some intervention, and they are kept on dual antiplatelets. So I'm curious that what is the safe time to stop both or at least one of them, and which one should be stopped first because they are already on the risk of bleeding? Thank you.
Very relevant question. So brief answer to that is it depends on the end result after the procedure. If they've had coronary intervention done, the stent results are very good and there's no residual disease left. They're in a safer zone. With the newer drugs, the newer stents, 4th generation stents, as long as the end result is satisfactory or excellent, the risk of stent thrombosis is very low after 1 month. So with cancer patients or high-risk patients, we can reduce the dual antiplatelet down to single antiplatelet safely at 3 months rather than whole year. Yes, if they can carry on for a year, fine. But if we need to step it down, we can say at 3 months, we can bring it down to single agent if needed. And if we have to choose between the agents, I would rather stop the aspirin and continue clopidogrel, which is slightly more potent so that they're at least better protected from the cardiac side and at the same time not at risk of bleeding complications. So 3 months is a rough idea. Second, if you look at the recommendations from the guidelines, they are encouraging intervention cardiologists to use intravascular imaging at the time of stent deployment. So when we deploy a stent, we can use an ultrasound within the coronary artery to look at the stent positioning and apposition with the coronary artery wall, and that's much more reassuring. So if the ultrasound is done at the same time, we are much more assured about the stent position and result, then even safer to stop the tablets earlier.
Dr. Asmin, please. Can we send the mic to Dr. Asmin, please? All right, thank you.
Thank you. That was very interesting. Small question, I guess, not. The balloon coated in drug, that sounded very interesting. I haven't heard of that. How does that compare to stents? And also, do the patients treated with a balloon also need to be on dual antiplatelets?
So the balloon angioplasty, so in the olden days, it used to be balloon angioplasty only before the stents came along. There was 30 to 40% recoil, hence the stents were needed. but those balloons did not have any drug coating on it. The drug-eluting balloons or drug-coated balloons are more in use for patients who cannot take blood thinners for too long, number one. If they've got branch disease and you don't want to put stent stress across important branches, or there is narrowing within the stent in future. The balloon works in exactly the same way. You will inflate it, achieve a result before you would put a stent in, and then another second balloon comes in with a drug coating on it, and you leave it in for about a minute. You block the artery for a minute, the drug gets distributed to the wall. That drug basically does the same job as the drug coating. It's the same drug which is on the stent, regulating stent. The difference is obviously the metal meshwork. So at the time of balloon inflation, if the lesion is prepared well with good flow, we can get away without a stent. If there's a lot of calcification there and the result is not that great, we are sometimes obliged to put a stent in. So we can try the drug-eluting balloon first. If the result is good, leave it alone. If not, sure, proceed with a stent. The recent data is coming out in not all comers. There's a subset of patients they've selected. There are some centers in UK where they're using more. There's one of the surgeons in Norwich whose practice is 80% balloons only. He's the leading implanter in Europe, and his results are excellent. It's also because of his experience. So you need a bit of experience with this. Yeah. There was another hand up earlier. Yeah.
Yeah, thank you.
Hello, my name is Chris Farnham. I'm a palliative medicine consultant who runs an acute oncology service as well. I think you highlight the difficulty that we often see patients in ED who are really sick, cancer patients, and we spend a lot of time trying to extricate them from our cardiologists who are fairly hardwired to treat these acute coronary syndromes. And as you've highlighted, sort of diagnosing end of life is really difficult. So my impossible question really is, how do we allow these patients to die from their heart disease, particularly when they've been told this is potentially treatable, when they're going to die perhaps a week or two later from their cancer?
Very, very realistic, challenging scenario. We do come across it occasionally. I think the key thing is communication. Communication with the patient and more importantly, the relatives, because you have to meet the expectations and sometimes unrealistic expectations, which are sometimes created by ourselves. So if someone has got 2 weeks to live and the first cardiologist comes along and says, we're going to put stents in, and then someone more sensible like yourself comes along and says, hold on, what's the point? I think the key factor in the management is symptom control. As long as we can get the chest pain under control, one way or the other, whether it's just a balloon without a stent or tablets, this is what they need, because everyone deserves to die with dignity. So they shouldn't be suffering with chest pain while they're dying from cancer. But at the same time, if I'm a cardiologist looking after such patients, I'll be extremely, extremely reluctant to do any kind of angiography or intervention if they're stable, because often they are not very mobile either. And if they're not going to be mobile, it is very unlikely they'll have exertional symptoms. So patient by patient, but tablets is as good as anything. Yeah. And this is exactly what we tell them as well. Listen, your relative is dying. We don't want him to die from any complication from a procedure that I might do now. Yeah.
Thank you so much for your talk. I'm Dr. Haris Siddiqui, I'm a medical oncologist at Shaukat Khanum, Lahore. I have a question basically on a patients, those who are receiving a chemotherapy with a curative intent, and somehow on a day 3, 4, they develop some acute coronary symptoms and found out to have some acute coronary event. So what would be your approach to such patients? Considering the neutropenia period and the low platelet counts such patients are encountering, considering the curative intent of the treatment with chemotherapy, would you be very aggressive with the PCI, or you would still wait for that time to over for in terms of neutropenia?
Thank you. My take on that would be, if a patient has come in with symptoms with dynamic ECG changes and a significant drop rise or troponin trend, which is going upwards, they're at high risk. And I would be a bit more aggressive with them. If they come in with normal ECG, very small or subtle troponin change, this might be, as I said earlier, type 2 myocardial infarction from chemotherapy or other stress factors, rather than a true coronary event. So rather than jumping into treating on day one, I'll probably give them 1 or 2 days for monitoring. Get an echocardiogram done in the meantime, make sure the heart function is good. Other risk factors will come in. If they misbehave in those 48 hours or so, it's just an arbitrary number, you know they're at high risk. Then I have more justification to be aggressive. But if in 48 to 72 hours, they are telling me themselves that they had no further symptoms, it makes it easier to make a decision on day 3. So the best thing is to step back a bit. Let time take its own course, allow us to get a bit more information, to have adjunct information to make a sensible decision. That gives us time to talk to them and the family. And in half cases, in my experience, patients themselves tell you what they want. Yeah.
So it's like patient in emergency department, which they come to us with chest pain, ECG changes, and they have low platelets. So how we approach those patients, because we can see the ECG changes are there.
So if the ECG changes of ST elevation MI, the recommended treatment is the same as non-cancer population because it's rapidly curable as well. And often it's a soft plaque, soft thrombus. You can suck it out. Sometimes you can actually aspirate the clot without having to put a stent in. So in those cases, we do jump in and do the procedure, make them symptom-free, ECG settles. You can then decide later what to do. I'll compare this with a scenario where when we in UK get ambulance calls for acute ST elevation MI, all we are told is we're 20 minutes away, 77-year-old, anterior MI, see you soon. That's it. We don't have their blood results. If they haven't diagnosed cancer, we don't know. If they're anemic, we don't know. We get the blood results usually after the stent is put in because the guideline is 2 hours. And by then, sometimes it's too late. So if it's an acute problem, we would rather treat that because it's curable and they may have better prognosis. Platelet count can be challenging. If it's really low, less than 30 or 3,000 or 30,000, whatever units you're using, we may have to be careful. We can still do an angiogram. As I said earlier, doing an angiogram does not mean we are subjecting them to long-term antiplatelet therapy. At least finding out the coronary status can be useful. But if the platelet count is chronically low, they are less likely to drop further. If it's an acute drop before we do anything, then it will drop further if we do more. So careful assessment in the first hour is important. But key thing is don't jump into doing anything in these patients.
Platelets.
Yes, if they have definite ECG changes and ongoing symptoms. Remember, the universal definition of MI is a combination of 3 things: symptoms, ECG changes, and troponin rise. Now, troponin will come back in a few hours. We don't need to wait for that. If the symptoms are typical with ECG changes, I would recommend give them antiplatelet therapy. It can be stopped the next day. 1 day of treatment will not cause too much harm. But what you don't want to do is if they are at risk of a major heart attack, you don't want to wait till the next day. So yes, do load them, but don't give them ticagrelor or prasugrel, which are the newer agents. Clopidogrel is safe enough with aspirin. And a lower dose of heparin. Probably a lower dose of heparin, not a full dose. Yeah. Yeah. Any other questions?
Right. It seems like there are no more questions now. Thank you, Dr. Sakib, for an excellent and informative talk.
Thank you.
Next in line, we got Dr. Waqas Shafiq. He's a consultant endocrinologist at Shaukat Khanum, Lahore. And I think he's going to talk about calcium. Thank you.
Thank you, Ahmed. So I'm going to talk about evaluation and acute management of hypo and hypercalcemia. So first, I will talk about hypocalcemia. I'm going to present 3 cases, and these cases will help us in finding the causes of hypocalcemia in cancer patients, which can be different from non-cancer patients. So the first case is a 41-year-old lady with a background history of breast cancer, presented with perioral numbness for 1 week and on and off diarrhea for 2 weeks. She has been receiving carboplatin as a part of her chemotherapy regime for the last 2 months. She had a corrected calcium of 7.84. She had a low potassium, low magnesium, phosphorus 3.9, and fractionated excretion of magnesium, which I will explain in a minute, is 12.96. As a reference, if it's below 3%, it's the GI loss. If it's above 3%, it's the renal loss. It's like when a body, when we are deficient in anything, like if you're deficient in magnesium, our body try to conserve. So that's how the renal conserve all the magnesium. We looked back previous calcium and magnesium, which were checked 4 weeks back, and it was completely normal. So initially, because she had a diarrhea and vomiting, everybody thought it's actually the GI loss, which is making low magnesium. And later on, when the diarrhea improved, and despite that, the calcium remained low, then it started investigating further. So this patient got a hypocalcemia secondary to magnesium depletion. Magnesium depletion can cause hypoglycemia by producing parathyroid hormone resistance, decreasing parathyroid hormone secretion. Therefore, a parathyroid hormone can be normal, low, or high in these cases. Platinum-based therapy, cisplatin especially, cause hypomagnesemia in 40 to 90% of the cases, whereas its derivative, either the carboplatin or oxyplatin, they can result in hypomagnesemia in about 10% of the patients. And the thing with these agents are that the hypomagnesemia can persist up to 6 hours after stopping these, up to 6 years after stopping these treatment. And it is primarily secondary to the renal loss of magnesium, as it causes direct injury to the renal tubules. It can also cause the magnesium loss because of the vomiting, diarrhea, and anorexia, which is associated with platinum-based chemotherapic agents. So how we can calculate that either it is a renal loss, we can do that by magnesium excretion in 24 hours by collecting a 24-hour urinary sample, where we can look at how much magnesium is lost in 24 hours, or we can check fractionated excretion of magnesium. It's very easy to check the fractionated excretion of magnesium. It's a spot sample. We need a urinary magnesium, urinary creatinine, serum magnesium, and urinary magnesium, and then we can use this formula and we can calculate. And as I earlier say, if it's above 3 to 4%, it indicates the renal loss. Now, how we treat them. So regarding the treatment for magnesium, hypocalcemia secondary to magnesium depletion, we can give them intravenous infusion initially, the magnesium infusion, and then followed by oral magnesium. The problem with the oral preparation are they're not very well tolerated. They can cause vomiting, they can cause diarrhea that make the thing more complicated. Now, there are multiple magnesium preparation. In Pakistan, it's only magnesium oxide is available in the oral form. In the West, magnesium sulfate is also available, which are slightly better tolerated. However, all the magnesium tablet, they can cause vomiting and the diarrhea. We can also ask the patient to increase the oral intake in the food. For example, the nuts, the figs, they have a good amount of magnesium. So that's one thing we can do. Now, these patients, they present to the hospital mainly secondary to hypocalcemia, because that makes them symptomatic. So one thing we do is we give them the calcium supplements, either IV or oral. And also we use active vitamin D like alpha calcidiol or calcitriol. The benefit with these agents are they can prevent hospitalization. I got many patients on, like they presented with hypocalcemia secondary to low magnesium, and we prevent them from hospitalization by giving them calcium and active vitamin D, along with on and off infusion of magnesium and like the oral medication as much as they can tolerate. Now, other treatment which we can use in these scenarios are two. They are potassium sparing diuretics or SGL2 inhibitor. Now, coming to the first one. So potassium sparing diuretics, amiloride and triamteride, they have shown to effectively reduce urinary magnesium excretion by increasing its reabsorption in the distal nephron. In Pakistan, we don't have amiloride alone. It's available in combination either with hydrochlorothiazide or with furosemide, because that's a diuretic agent. And the problem with the hydrochlorothiazide is that it can also increase the magnesium loss. So that's one thing which make it difficult to manage these patients. However, we have used the amiloride and thiazide, and it actually did help in patients, although it didn't help as much as the alone amiloride can help. Now, sodium glucose co-transporter inhibitor. These days, these are the medications which are used everywhere. So renal patients, it show improvement in the renal function in diabetic patient. Cardiologists use it a lot for heart failures, and also there is evidence of improvement in improving the cardiac outcomes in patient, especially with the diabetes. Now they have checked that for hypomagnesemia as well. And what they found was that it actually increased, as the way it increased the urinary glucose excretion, it reduced the excretion of magnesium. And that's, there was a meta-analysis where they looked at 15,000 patients, which showed significantly higher serum magnesium level in patient treated with SGLT2 inhibitor than in those ones who were left untreated. And on average, it can increase the magnesium by 0.15 to 0.24 milligram per deciliter. Now, the problem with the SGLT2 inhibitor are they do increase the risk of urinary tract infection. And a lot of the time, the carboplatin and cisplatin, they are used in patients who got a uterus or cervical cancer, where they are already increased risk of obstructive uropathy. And that can be a challenge to give them on SGLT2 inhibitor. So that's one thing to keep an eye when we give the SGLT2 inhibitor to these patients. Now, coming to the second case. So a 60-year-old lady with a background history of breast cancer and osseous metastasis. She was found to have low calcium while investigating for tiredness, lethargy, and numbness. Corrected calcium was 7.3, magnesium 1.2, creatinine normal, parathyroid 160, mildly raised, 25 hydroxy, vitamin D was never checked. She has been on zoledronic acid every 6 months for the last 3 years. Now, what is the cause for her low calcium? Anybody can say what it could be? So it's actually the zoledronic acid. So parenteral administration of osteoclast inhibitor like zoledronic acid, palmidronate, and denosumab, they reduce the frequency of skeletal related events among the patient with advanced malignancy. Previously, they were used originally for osteoporosis, and we used to give them once a year. And that was the main aim of the treatment with the zoledronic acid. However, there is a lot of data regarding the use in the cancer population where it reduced the metastatic bone metastasis in cancer patients. So now the oncologists are using it 6 monthly, 3 monthly, and yearly. The way the zoledronic acid work, they actually cause osteoclast inhibitor. They are osteoclast inhibitor. So calcium homeostasis is one of the major function of the bone. The osteoclast reabsorb bone and release calcium. These inhibition can result in hypocalcemia and hypophosphatemia. Most patients do not become hypocalcemic because of the compensatory mechanism. For example, the high parathyroid level. However, the patient where this mechanism are blocked, for example, they have a prior parathyroidectomy, they have a low vitamin D level, they have low magnesium, or they are hypoparathyroid and renal failure, they can develop hypocalcemia. There's a case series of 120 patients who receive a total of 546 infusion of zoledronic acid for multiple myeloma or other malignancies. And it was found that the 10% of the patient, 10% of these infusion resulted in hypocalcemia. Symptomatic hypocalcemia requiring IV calcium was developed in 8% of these patients, even when the dose was calculated for creatinine clearance and they were supplemented with oral calcium and vitamin D. impairment of the creatinine clearance was more often among the subject developing hypocalcemia. Hypomagnesemia was found in all patients who develop hypocalcemia when it was checked. So it's a retrospective analysis. So not everyone magnesium was checked, but when it was checked, they found that it was low. So it's another risk factor for cancer patients who have low magnesium. They're very prone to get hypocalcemic if they receive zoledronic acid or denosumab. How we can prevent it? So daily supplementation of calcium, vitamin D, these can be used unless the patient already got a hypercalcemia or history of renal stones. These patients, if we supplement them with the calcium and magnesium, that can prevent the hypocalcemia secondary to zoledronic acid. And then we also need a frequent monitoring of calcium. For example, it's advised to check the calcium every 3 months for patients who are on zoledronic acid, and especially more frequently in patients who have got a renal insufficiency as well. Now, a third case, a 26-year-old lady who underwent total thyroidectomy for papillary thyroid cancer. 24-hour post-surgery, she developed perioral numbness and spasm of the arm. The corrected calcium was 7. Before surgery, her calcium and vitamin D level was completely normal. So here, the cause is hypocalcemia post-neck surgery. If you look at surgical hypoparathyroidism, can occur after thyroid surgery, after parathyroid, or radical neck surgery, especially for head and neck cancer. The transient hypoparathyroidism occur in about 20% of the patient after surgery for thyroid cancer, and hypoparathyroidism in about 0.8 to 3% of the patient after total thyroidectomy, particularly when the goiter is extensive and the anatomic landmarks are displaced and obscured, which is very common in patients with cancer. How we treat them? So the treatment depends upon how quickly they develop hypocalcemia. For example, patient whose calcium is completely normal and they had a surgery and they develop hypocalcemia, they could be very symptomatic. They can develop arrhythmias. However, in patient who has been chronic hypocalcemic, they don't have many symptoms other than tiredness, numbness. That's the most common symptom. But when they develop acutely, that's when they are very symptomatic. They can develop the spasm, carpopedal spasm, with the acute fall. So in patients who have acute hypocalcemia, where there is a rapid fall, we always give them a calcium infusion. Calcium infusion could be either calcium gluconate or calcium chloride. One thing to important for these patients are that it need to give through a good IV access, because if it's extravasation of calcium, then it can result in a skin gangrene. For chronic hypocalcemia, we treat them with oral calcium. We treat them with alpha-calcidiol, calcitriol, which are active vitamin D, and thiazide diuretics. So thiazide diuretics have a function. They reduce the renal excretion of calcium, and that's one thing which we use as a part of the treatment of hypocalcemia. So next, I'm going to talk about hypercalcemia. So let's start with the first case. So it's a 30-year-old lady. She had a background history of thyroidectomy for medullary ciliary thyroid and left adrenalectomy, which was pheochromocytoma. She was found to have hypercalcemia on 6-monthly routine blood test. Calcium was 6, calcium was 10.9, PTH was raised, and parathyroid scan show uptake in the inferior parathyroid gland. So the diagnosis in this patient is primary hyperparathyroidism on the background of MEN2. So the treatment for these patients, we remove 3 of their glands and put the 4th one in the forearm, because there is a very high risk of recurrence in these population. And that's why we put 1 parathyroid gland in the forearm. So in case if they develop hypercalcemia again, then that can be easily removed rather than going for a surgery again. So a second case, which is the common scenario which we see in a cancer hospital, a 70-year-old lady with a background history of metastatic bowel cancer presented with polyuria, polydysplasia. Her calcium is raised. Her parathyroid hormone is actually low or suppressed. Creatinine is normal. The diagnosis is hypercalcemia of malignancy. Now, hypercalcemia is very common in patients with cancer, which happen in about 10% of the cases. It mostly occurs in patients with advanced disease, and it is an indicator of poor prognosis. The most common tumor that cause hypercalcemia are breast cancer, renal cancer, lung cancer, and multiple myelomas. We did a study in the Shaukat Khanum where we actually look at patients who presented and admitted in the Shaukat Khanum with hypercalcemia between July 2019 to 2020. There was 173 patients who presented, and we found that the median overall survival for these patients who presented with hypercalcemia was only 51 days. It's well documented that hypercalcemia is extremely poor prognostic marker, and this is what we noted in our study as well. If you look at this chart, you can see that 40% of the patients died within 30 days. And by 90 days, 75% of the patients were already died within 90 days of their presentation with hypercalcemia. So this is one of the very bad prognostic marker for cancer patient to develop hypercalcemia. How the cancers result in hypercalcemia? There are three mechanisms. Either there is a tumor secretion of parathyroid hormone-related protein, either the osteolytic metastasis with local release of cytokine, including osteoclast activating factors, or tumor production of vitamin D. So how we treat them? So the treatment include intravenous infusion, because that results in increased urinary volume and increased urinary excretion. We can use subcutaneous calcitonin. That's not available in Pakistan, but that is shown to result in a rapid improvement in the calcium. However, that improvement doesn't last for long. So the main treatment is intravenous bisphosphonate, typically zoledronic acid. We can use pomidorate as well, but they start working after 4 to 5 days. So we have to wait for 3 to 4 days before looking for any significant improvement in the calcium level. We cannot expect that we given the IV zoledronic acid and the calcium will be fine in the 24 hours, but it will take 3 to 4 days, and the effect does last for months. Sometime the calcium is still not improved and we end up giving another dose, but it is recommended not to give another zoledronic acid for at least a month. The other treatment, denosumab, that's also an osteoclast inhibitor. They can be used in the hypercalcemia. It's not available in Pakistan, but in the West they use it. But the results are quite similar between the denosumab and zoledronic acid. Dialysis sometimes can be indicated in patients with severe malignancy associated with hypercalcemia and impaired kidney function or heart failure in whom hydration cannot be given safely. However, as I mentioned earlier, these patients got a very poor prognosis with a median survival of less than 51 days. These patients, we have to think of either we really need to give them a dialysis or not. That's all. If there's any question, I'm happy to answer. Thank you.
Thank you, Dr. Waqas, for another excellent presentation. Any questions from the audience? Don't see any hands so far. Oh, there you go.
Abdul Wahid, I'm colorist from Peshawar. Thank you very much for your nice presentation regarding this hypercalcemia and others. What do you think about the hypercalcemia using diuretics and steroids, please?
So steroid, the furosemide can be used in these population. However, a lot of the time they are dehydrated. So we normally don't give them routinely. It's better to give them zoledronic acid and fluid that have a better result. Regarding the steroid, there is some role in patients, for example, with the lymphomas and multiple myelomas and things where you can use the steroid. However, again, that effect doesn't last for long. So the best treatment is still the zoledronic acids.
As the zoledronic acid starts functioning after 4 days.
Mhm.
So during this time, what do you think about the combination with this steroids plus diuretics?
They say they can be used. However, the evidence is not a lot even with the steroids, because even if you use the steroid, unless if it's coming from lymphoma, leukemias, or multiple myeloma, there is not a lot you can improve. You can certainly can give it and give a go, but it's not recommended in any guidelines to use it as a first line. So first line still will be the fluids, and then you go on the zoledronic acid, and most of the time it does improve.
Another question about regarding the magnesium deficiency. You
Mhm.
told that it stays for a very long time.
Mhm.
So, do you think that the magnesium injection form or the tablets or other supplements should be given for how long?
So it's all depend upon how long the deficiency remain. So we have few patients where it lasts for we followed them for 2 to 3 years, and they finally they died. But actually they did require the magnesium throughout. Um, they actually we were giving them oral magnesium regularly, and they were getting magnesium infusion as per required. So we were checking them, like initially we start checking the magnesium every week. If the magnesium was below 1.3, we do give them IV infusion. However, if it remain above 1.3, we don't give them IV magnesium. We keep them on oral, and we start looking into the agents. As I mentioned, amyloride. That's actually a quite good agent to use it, and we used in our patient with quite good results. And another benefit with the combination of amyloride and thiazide are they improve your calcium as well. Because as I say, a lot of these patients got a symptom mainly secondary to low calcium.
You are quite right, because this is usually we use this cisplatin, carboplatin, and other platin compounds. So there is usually magnesium and potassium depletions from the body. We usually replace it along with it. But I didn't know that it can stay so long for even years. I didn't know this. So
Yeah. No, majority of the patient, it lasts for months, but there will be few where it can last up to 6 years after stopping.
thank you.
Right. So, I think no question from the audience. One quick thing, Dr. Vikas, you just mentioned that our local data from Shaukat Khanum. So 75% of the patients were not with us,
Yeah,
like within 2 months.
Yeah.
So is that a time to start talking about the palliative care when a patient arrives with hypercalcemia for the first time? Because 3/4 of the patients will not be with us within 2
So
months.
that's what the main reason for bringing this slide is, that the hypercalcemia is associated with bad prognosis. When we did our study where we looked at all the admission with hypercalcemia, and these are those ones which are from cancer patients. These are like the hypercalcemia is secondary to the cancer. We excluded the patients who have a high parathyroid level. And these patients, 173 patients, when we looked at, there is median survival is only 51 days. And if we actually add hypercalcemia and ECOG, then if they, for example, patient who had a poor ECOG and hypercalcemia, the median survival was actually 25 days when we look at that data. And people with impaired conscious levels secondary to it, it was similar. So as you can see here, 40% of the people died within 30 days. And actually by 90 days, 75% of the patient died already. So that's, I think, one of the marker which we could use it, that either these patients should go aggressive chemotherapies in things who already develop hypercalcemia, and they got a low ECOG, then the outcome is very, very poor. And this is not the data this is not like we have seen in our hospital. This is the data internationally, because when there is a hypercalcemia, that's a point where it means that we might need to look at palliation rather than the active treatment.
Thank you, Dr. Vikas, for another excellent presentation. So we got all three speakers with us. Dr. Asim is here, Dr. Sakib is here, Dr. Vikas is here. If there are any, I can definitely see the hall is full now. That wasn't the case at the beginning of the talk. So if there are any other questions you may want to ask Dr. Asim's talk on upper GI bleed, or Dr. Sakib's talk with the coronary events in cancer patients, or Dr. Vikas.
There is some online questions, I think, which I'm not sure whether you can see those ones or.
I don't think I have access to that. There we go. A few on the screen we can see. So I can read one of that. Ask Malcolm, a patient scheduled for low GI oncology surgery, major surgery, have sedentary lifestyle, has history of ACS followed by medical treatment, limited activity. What would be the best investigation to evaluate?
Symptoms. As I said earlier, if their symptoms stabilize with treatment or tablets, sedentary lifestyle, limited activity, suggesting there's an element of frailty, I think I would be promoting conservative medical therapy here, which is as good as stents, as I said earlier. So investigation-wise, for surgery, a non-invasive test, like a stress echocardiogram or perfusion scan. Stress echo is probably preferable because stress echo gives you information on the valves in addition to other things, which perfusion scan might not. So use of stress echocardiogram can be very useful in these patients prior to surgery.
Brilliant. Thank you. We've got a question, I think, for Dr. Asim. Are antibiotics recommended for every upper GI bleed prior to endoscopy? No, okay.
Okay. Yeah, no, the answer to that is no. Antibiotics are recommended prior to endoscopy if you suspect that the bleeding is from varices, esophageal or gastric varices. You won't always know that, but you can be guided by the history. If there's an obvious history of chronic liver disease, the patient is positive for hepatitis B or C, and particularly in a cancer hospital setting, if they've got HCC, for example. So it's based on your clinical judgment as to whether the likelihood is that they're bleeding from varices. And if there's any likelihood, then it's safer to give a first dose of antibiotics. You can always stop them after the endoscopy if bleeding is from elsewhere.
Sure. Thank you. And then we have, do we have any recommended hydration protocols for hypercalcemia? That's for Dr. Vikas.
So we normally suggest to give 3 to 4 liters of fluids in 24 hours, but that definitely depend upon the patient condition. Either they are fluid overloaded or dehydrated, but the recommended dose is recommended regime is about 3 to 4 liters in 24 hours.
Do you want to come to the mic, please, for the question? Thank you.
Assalamu alaikum. I'm Dr. Sidra. I was summoning up some courage because my English is not good. My question is for you, sir. You presented 2 cases. I'm fine with the second case, but not the one. Don't you think the percutaneous intervention was more important for him to wait for the surgery, because he had already BCC and that BCC is very slow growing? And you mentioned that it was his second surgery. It means there was a residual disease, not the first one. So why did you wait? Patient was asking to wait for percutaneous intervention, but was it not good to first undergo PCI and then to go for the second surgery? Thank you.
A very good question. And my first comment is that your English is excellent, by the way. So don't feel bad about that at all. I'm really happy for that. Regarding this particular patient, if you remember, this particular patient did not even want to stay in hospital. If you remember what I said, he wanted to go home the same day and get his cancer treatment as an urgency. He did not want anything done, but we convinced him to stay in for the angiogram at least. At the time of the angiogram, when we saw the lesion, we were contemplating whether to put a stent in straight away or not. The only difference would have been putting a stent in, and that although it's a recurrence of his cancer, it was growing not so quickly as you said, but yes, within a month it had doubled in size. So he wanted to get it treated. His mind was fixed. We convinced him to delay his surgery by at least 2 weeks, but he wouldn't wait any longer. I think the surgeons were keen to get it done soon as well, because it was localized, easier to do for cosmetic reasons before it was bigger. Stent wise, it was an easy stent to do. As I said earlier, probably 10 minutes, stent would be in. If this patient comes back to me, I would use drug-coated balloon without a stent. So there's no stent there, but we'll treat the lesion. And this is what we discussed at the time. We gave them the options on the table. We said, you can do it now, 3 months of dual antibiotic therapy, and then have your cancer surgery. His preference was to get the cancer out first. And in retrospect, he's done fine. 4 months down the lane, he's had no further angina whatsoever. So although, yeah, visually it looks like 80%, 90% stenosis, clinically he's done very well without a stent.
Thank you. Well, it doesn't look like there are any other questions at the moment. So thank you everyone for joining the session. And thank you all three speakers for excellent talks and very informative talks. I would like to conclude the session now. Thank you.